What exactly is a hypertensive crisis, and why is it critical to comprehend its implications? Imagine a sudden spike in blood pressure, hitting levels upwards of 180 over 120 millimeters of mercury. This is not an ordinary high blood pressure scenario. It's a hypertensive crisis, a condition that can cause severe damage to critical organs like the brain, eyes, cardiovascular system, and kidneys. There are two main categories of hypertensive crises: hypertensive urgency and hypertensive emergency. Each presents its unique challenges and requires different approaches for management. In a scenario of hypertensive urgency, the crisis often slips under the radar, presenting no noticeable symptoms or only vague signs like a mild headache, dizziness, or nosebleeds. It's the silent intruder, the ticking time bomb. And yet, despite the high blood pressure readings, there's no immediate damage to vital organs. However, the situation escalates when we move into the realm of hypertensive emergency. Here, the crisis is accompanied by acute damage to vital organs such as the heart, brain, or kidneys. This is the red alert phase where immediate medical attention is paramount. So how exactly do we manage these crises? In hypertensive urgency, immediate intervention is not typically required for asymptomatic patients. Those presenting non-specific symptoms may benefit from moving to a quiet room for about 30 minutes, followed by another blood pressure reading. If symptoms persist and are linked to high blood pressure, a rapid-acting oral antihypertensive agent may be considered, with options ranging from clonidine and captopril to labetalol and prazosin. It's crucial to monitor these patients for a few hours to ensure blood pressure and symptoms improve. But what about a hypertensive emergency? The stakes are higher here, and the choice of treatment hinges on various factors, including the rate and targets of blood pressure lowering, the end organ affected, underlying disorder, and patient comorbidities. Intravenous medications are usually required, with a list of options that include calcium channel blockers like nicardipine and clevidipine, nitric oxide-dependent vasodilators such as sodium nitroprusside and nitroglycerin, direct arterial vasodilators like hydralazine, antiadrenergic drugs like esmolol, labetalol, and phentolamine, and ACE inhibitors like enalaprilat. The specific agent chosen is tailored to fit the individual patient's needs and condition. In conclusion, understanding hypertensive crises, their types, and management strategies is crucial. We must remember that these crises are not just about high blood pressure readings. They're about potential organ damage, about life and death situations, and knowing how to respond is key.